Good morning. I'm Jon Elion, President and CEO of ChartWise Medical Systems. We're the premier company with computer-assisted clinical documentation improvement with built-in artificial intelligence that helps you to review the charts and get them better. And we've been head of the class report, KLAS. If you're not familiar with it, I like to think of it as the J.D. Power of customer satisfaction in hospital software, and we've been lead in our category for the last 2 years. I'm also a clinical cardiologist, so remember the old saying about the fellow who ran the hair club for men? He said, I'm not just the president, I'm also a customer. So I do write notes, and I do have to improve my own clinical documentation, so I'm kind of on both sides of things. And I'm just thrilled to be here on Healthcare Scene today. Most exciting thing for me is the move away from the monolithic systems. Now that deserves a little explanation. We've seen a pendulum swinging back and forth over the years, and on one end is best of breed, and on the other end is the monolithic system. You'll get everything you need from me, don't get anything else. And that pendulum swung awful far in this direction recently, where some of the big companies were trying to say, get all of your stuff from us, and we're fully integrated with ourselves, which isn't always true. And now, largely through some of the federal initiatives, the monolithic systems are opening back up again. And hospitals have spent a long time in their infrastructure and with interoperability, and one single company simply cannot be best at everything. So the opening of these monolithic systems as the pendulum swings back to a more sane position is very exciting to me. Scariest thing, and this is going to take some explanation. I'll use the word first, and then I got to come back and explain it, and it is iatrogenic. The word iatrogenic is an error introduced by the physician, from the Latin term iatros, for physician, and everybody knows about iatrogenic errors. Iatrogenic errors are errors in healthcare introduced by the use of the electronic medical record. Now, I just came off of a very intense week in the intensive care unit, being cardiologist for a very large population of very sick people. We have a very sophisticated modern EMR. I won't name the vendor, but when I would sit down, I would feel that I was at the cockpit of the 747, and I was besieged with all of these lights and dials and buttons. And there were many quirks that if I got into a note one way, it would behave one way. If I came in a different way, it would behave a little bit differently. And I'm inundated with information, which is okay. That's state of the art of medicine these days. But I found it very difficult, and I'm not talking about the EMR is getting between me and the patient. That's what many physicians complain about. I'm simply talking about the fact that everything was so electronic was very difficult. I need to tell you one quick story. I'm going to date myself now. I did my internship in 1975. And the office for the interns and residents, there was an inbox, and all of the lab data, as it became available, went into that inbox during the day. At 4 o'clock, we would sit down and go through every slip of paper. We handled every slip of paper. Every incoming lab test was reviewed. I do not have that functionality on a modern EMR all these years later, interestingly. Yes, there's places that incoming results are there, but they're scattered with so much other data, it's very hard to pick out just the new test results. So in general, I think the reviewing of the results, I'm still getting results weeks later coming in on patients that maybe I don't remember as much, and I'm going, am I the only one reviewing this? Is anybody else seeing this? And so iatrogenic, very scary. And I struggled with that question. And I think the struggle is interesting, and I'm reminded of Y2K. Now, maybe you read about it in the history books, but when Y2K came along, there were all these dire predictions about what was going to happen. We all woke up January 1st, 2000. The television stations were there, the newspaper got delivered, the lights were on, the utilities were working. It was kind of a big non-event. And there were so many naysayers about ICD-10, so many doomsday predictions. And October 1st came around last year, and everything continued just fine. It's unrealistic to think that ICD-10 itself was going to have a major immediate impact on healthcare, but we are gathering data, more complete data, and that's very important. Just some quick examples. There was no code for the Zika virus disease in ICD-9. No code for Ebola. So adding those kinds of things, very important for us to track and have accurate data and to keep up with modern healthcare. Two words, data aggregation. We have a lot of data, and a lot of the big EMRs, and let's face it, there are 2 to 3 major EMR vendors in the inpatient world, and yet they're not yet really capable of aggregating their data across institutions. And if you have an EMR from one particular vendor, people would assume that that EMR is then similar to the EMR installations at all the other sites that vendor has. It's not necessarily the case. You buy a box of Lego blocks and you spend 2 years building your EMR, which, while it is the same brand as the next hospital with that vendor, it is not really the same EMR. And we've not yet seen the de-identification and the anonymous aggregation of data. There are standards for this, and IHE, Integrating the Healthcare Enterprise, is really pioneering at the standards and the collection of standards needed to collect and de-identify that data. Leave the data in the hospital while still have the indices and the ability to aggregate that up. So that's been around for a while. It's not really been implemented well, and I think the next 5 years we're going to see that data becoming live and in real time, and not telling me what the data aggregation was from 3 years ago. That's actually very easy for me, because you won't be here with me in 20 years finding out whether I was right or wrong. Again, I'm going to date myself, but I'm reminded being in medical school and learning about mercurial diuretics. And we were all shaking our heads going, how primitive. Oh, that's just terrible that they were giving those poisons to people to help them pee away their extra fluids. And I can't help but think that 20 or 30 years from now, people will be sitting going, they used to give chemotherapy for breast cancer. Can you imagine how primitive to give those toxic agents? So 2 areas that are both related to genomics and gene sequencing. One is pharmacogenomics. We know that people handle drugs in different ways, and we're learning about genes and gene types that affect the way drugs are given. So we used to give broad spectrum antibiotics, then people figured out you can do a culture and sensitivity. You can find out exactly what drugs are affecting the bacteria, and we're learning that in pharmacogenetics, and we're doing it by gene sequencing and learning a little more about giving better targeted therapy. The other aspect, again, it's also targeted therapy, is in the cancer world, where we're giving broad spectrum chemotherapy without really understanding the sensitivity of the individual cells that a patient has to that drug. In the future, and we've already made major strides in drug selection, but you've probably read about some of these targeted therapies using your own immune system to fight off the cancers. And I look forward to the day, and it may not be 20 years off, it may be sooner, when we'll sit back and we'll go, can you imagine them giving that toxic chemotherapy? How primitive.